Either way is okay, sir.
Okay, that's fine. Like in the either way, it's okay. That means like maybe you guys can take turns and you can answer, or you want me call by the name.
Volunteer. People will volunteer, sir.
Okay, that's fine.
Okay, sir.
So in between, if you have any issues, if you can't hear well, the screen is not good, please inform me, man.
Okay, sir.
Okay, I think Alina can inform any changes. Yeah, any
Yes.
difficulties to hear or difficulties to see.
Okay, sir.
Okay. So okay, good evening. I think I guess
Good
you're
evening,
all fine.
sir.
Good evening. You are all final years, I guess. So thanks to Alina, she prepared some material. She gave it to me. I'm going to say that also. So the final year, and there are two things why you are here today for next 1 hour. One, you're going to pass the exam. One is the theory part, and the second one is the your clinical part. So theory part, clinical part, and third thing, once you become an house surgeon, if you face these children with heart problem, how you are going to manage. So these are the three things you are going to get it. I think the third thing you can learn later also. The first two things, you're going to clear your exam of this final year exam confidently in the case of pediatric cardiology. I'm going to cover today the congenital heart disease alone. So maybe later on we can have, if this class works for you, probably we can have the second session of rheumatic fever. So the pediatric cardiology is the easiest chapter in the pediatrics. Comparing to the all specialties, the pediatric cardiology is very easy one. Here if you see this one, the essays you got in last few years, this slides prepared by Alina, thanks to Alina, and acute rheumatic fever, rheumatic mitral stenosis, treatment of this fever with the carditis, and discuss the prognosis. These are all questions related to rheumatic fever. Other thing, what you got it in exam, classify congenital heart disease, discuss the hemodynamics, assessment, severity, complications of VSD. And the last question is congestive cardiac failure in children. So I'm going to cover the last two topics today. The short notes wise, what you got is management of CCF and infective endocarditis prophylaxis and persistent pulmonary hypertension in newborn. It's called PPHN, Fallow's tetralogy, cyanotic spell, and Eisen-Menger syndrome. These are the short notes they asked in recent years. Short answers. So what you got? You got types of VSD, digoxin toxicity, pulse and BP in coarctation of aorta, and the innocent systolic murmur, and the common causes of childhood hypertension. These are the recent questions they asked in theory. So this next 1 hour is going to cover all the congenitally related topics, and that would be useful for your exam. So before going for from the theory point of view, then next you go for clinical. So clinical, I heard you get three types of cases. So one is called ventricular septal defect. The second one is called tetralogy of Fallot, and third one is patent ductus arteriosus. So one of you can tell me in one word how you pick up these three conditions, one or two sentences. One of you. One of you can say one or two sentences. You pick up these cases by within less than half a minute. You have to pick up what case you got, whether it's an VSD or PDA or is it tetralogy. One of you can volunteer and you can answer how you pick up these three thing cases without help of the your postgraduate or assistant professor in the college. So no answer. Okay, that's fine. So you can pick up these three cases by simply, you have to see the child's hands. If you see any clubbing, and if it is a cardiology case, then you can close your eyes and you can present as a tetralogy of Fallot. There is no other diagnosis you will get with the clubbing for the exam for the final year level. It's a tetralogy of Fallot. So tetralogy of Fallot, so you can prepare the case by seeing the child's clubbing if it is a cardiology case. Second thing, ventricular septal defect and patent ductus arteriosus. How to pick up VSD and PDA by seeing. After seeing the child's clubbing, if there is no clubbing, then you feel the pulse. If you feel the pulse and the pulse is bounding, it should be likely PDA. Or if they keep the rheumatic heart disease, you have to suspect aortic regurgitation. So if it is a congenital heart disease, if you feel the pulse, it's the bounding pulse, it's likely the case could be PDA. And you double check the PDA by doing the clinical examination, keeping your stethoscope and the stet over the chest. If you see the stethoscope and if you keep the stet and if you hear a murmur, obviously how to differentiate PDA murmur and VSD murmur you should know. It's very simple. Anything above the nipple line of the baby, if you hear a murmur with the bounding pulses, that's a diagnosis of PDA. And any murmur you heard below the nipple line, then you best heard. So murmurs will be, whenever you heard the murmurs, it's not like adult. In children, you tell where you best heard. The child's chest is so small, you have to differentiate by hearing the best. You can't really saying by the spaces. Can't really tell second space, third space, fourth space. It's all challenging and it's difficult. You have to say, I heard best in this area. So the murmur you will hear everywhere. But wherever you best heard, if you heard any murmur below the nipple line and there is no bounding pulse, that's a VSD. Any murmur above the nipple line, that's going to be your PDA. So it's very easy to pick up these three cases. Whenever you go to practice, you see the cases, children cases, congenital heart disease, usually they will be under 5. Rheumatic heart disease usually over the 5. So under the 5 children, if you think it's a cardiology case, you just to try to differentiate based on these three things. So you will get the cases. So now we move to the, so now we covered the theory part of view and practical part of view. We're going to talk a little bit about the pediatric cardiology with the congenital heart disease. So do you know like the discipline of pediatric cardiology developed in United States in the late 1800s.
Sir, excuse me,
so
sir,
late
one second.
1800s.
Sir, so your voice is not very...
Can you hear me, ma?
I can hear you, but it's not very clear, sir. It's kind of muffled.
Wait. Muffled. Okay, maybe I will just close this door and I'll be.
Okay, sir.
Society of India, there will be almost 100,000 children born with the congenital cardiac problem. So in this one, half of them are very critical, but we are able to help only 20,000 children either with a surgery or intervention. So we are not sure about what's happened to the remaining. This is a very important point. As you're going to be a doctor very soon, it's very important to pick up these congenital cardiac problems and you have to refer appropriately to the appropriate doctors. It's a very important. Whoever is listening to this lecture, I really don't want you to miss any of the congenital cardiac services in your practice. And it's very easy to pick up these things that I'm going to teach you in next few slides. So it's a very simple subject, but we really don't want any of whoever is attending this session to miss the congenital cardiac service. How to pick up and the missing cases, how we are going to pick up. So two ways you can pick up. One is the diagnosis. The diagnosis part, if this specialty includes not only the postnatal, even it's an antenatally. Antenatally, you can easily pick up most of the heart diseases by the 20 weeks of gestation. And after the postnatally, if something missed in antenatally, we can pick up all the diseases by postnatally. So there is no point in this era of modern era of cardiology to missing any of the cardiac congenital things. How do you treat? You treat with a surgery or intervention. Sometimes you don't need to do anything. You just do simply you follow. You just remember this. You can diagnose from antenatally and even postnatally. The treatment is most of the times one third of the diseases will spontaneously resolve and the remaining may require a surgery or intervention. So whenever you describe, like whenever we describe a thing in pharmacology, if you ask side effects, we always tell nausea, vomiting, or if we always write something. So similar way, even the congenital heart disease, if you understand the pathophysiology, it's easy to tell a few points. For the final year level, you don't really need to worry much about pediatric cardiology. So that if you know some protocol, what to say. If you say some heart condition, you are able to say some points. That's very easy to say. So you should understand what is congestive cardiac failure, whether that lesion will cause congestive cardiac failure or not, and you should able to say a time of onset. So when will occur the cardiac failure and the what are the symptoms and signs of the congestive cardiac failure and how you are going to manage this congestive cardiac failure. If you know these three things, whether your condition, for example, if you take atrial septal defect, so then you should know whether atrial septal defect will cause congestive cardiac failure or not. If it causes congestive cardiac failure, you should know the time of onset of ASD causing congestive cardiac failure. And you already know what are the symptoms and signs. I'm going to tell in next few slides. You can write down all the symptoms and signs and the management part for treating congestive cardiac failure. If you know for one condition, you can write for the all the congenital heart diseases which causes congestive cardiac failure. So in other words, you should study congestive cardiac failure in detail about the conditions which causes congestive cardiac failure and the symptoms and signs and management. You can answer any of the questions they ask in pediatric cardiology. But again, the second thing you should understand, there are some inherited syndromes. Example, Down syndrome will always associated with 40% will associated with atrioventricular septal defect. So the same way, Turner syndrome will associate with coarctation of aorta. So if you should know inherited syndromes will associated with this one. So you can write again this point and the examiners also will ask common syndromes which causes congenital heart disease. You should know few syndromes and you should know associations. Prenatal exposure. This is very important in your history. When if you're going to take a case, you should ask them prenatally anything happened. So what are the prenatal things which you will ask a mother if you suspect in the baby a congenital heart disease? One of you can answer. Prenatal exposures for the congenital heart disease.
Diabetes.
Correct? Diabetes, very good.
Any drug history?
Correct? Drug history.
Rubella, torch infections.
Correct. Yeah. So as long as you know these three things, these are the very common things you should know. So infant of diabetic mother on insulin. So not, I think if you see most of the antenatal mothers nowadays having gestational diabetes. Gestational diabetes is not much associated with congenital heart diseases, but mother on insulin will have a more high risk of having the congenital heart diseases. So that's very important history. And second thing, as you rightly said, medications. You should ask for any medication in history, then they have the associated problem. Rubella. So rubella, what is the triad of rubella which causes rubella, congenital rubella syndrome in mother? Baby. One of you? Congenital rubella syndrome. The triad of congenital rubella syndrome. 1, 2, 3. What are the diseases you will get?
Deafness.
Deafness, very good. One.
PDA cataract.
Correct. That's it. So you get the PDA and cataract, so blindness, deafness, and associated congenital problems. So the rubella will have these things. So any question if they ask, you can remember these things: inherited syndromes, prenatal exposures, congenital causes. Other important thing to remember: the circulation of hemodynamic circulation of congenital heart disease. So you will classify congenital heart disease based on they are cyanotic or acyanotic. So this classification also it's very important. So all the acyanotic heart diseases will lead to the congestive cardiac failure at some point of their natural history. The same time, all the cyanotic lesions, as it says cyanotic lesions, they will have a cyanosis. So you should study two things in your pediatric cardiology. One is all about congestive cardiac failure, and the second thing you have to study is the cyanosis. What is cyanosis? How it will affect the cyanosis? What are the cyanotic congenital heart diseases? And then you can very easily you can write whatever the question they ask in exam, whether they ask essay, whether they ask short notes, or whether they ask even short questions. Whatever they ask, you can write as long as you read congestive cardiac failure. If you read about the circulation based on the cyanosis, and further imaging you do all the nowadays the echocardiogram is the gold standard examination. So even though we believe the clinical examination and history is very important, but at the end of the day, to do something, to confirm something, we need an echocardiogram. So echocardiogram is an investigation which is easily available now and it's very safe to do. So the imaging part, it comes in a echocardiogram, and traditionally we do ECG and chest X-ray. If it is a complicated cases, they may need even MRI and CT, and to assess the pressure across the chambers and the pressure in the pulmonary circulation, we may need a cardiac catheterization. So if you remember this single slide, you can write down, so causes, then you can write down the symptoms and signs, and you can write a bit of inherited syndromes and prenatal exposures, then you are able to answer your questions. What is the physiologic CHD? I was telling you earlier slide, physiologic CHD, congenital heart diseases. You divide into acyanotic shunts, acyanotic obstructive, cyanotic with a reduced pulmonary blood flow, cyanotic with increased pulmonary blood flow. So this classification you have to remember. It's very easy to remember. You take heart as a chambers, 4 chambers, and the heart got 2 tubes comes as an outlets, and there are 2 inlets. So if you just to do it, it's like a max. You have to take it ventricle. Across the ventricle there is a hole, it's called VSD. Across the hole, across the atrial septum, it's called ASD. And what is AVSD? One of you can answer. What is AVSD? Is it VSD plus ASD, or is it different? What is AVSD?
Atrioventricular septal defect.
Correct. That's the expansion for AVSD. What is atrioventricular septal defect?
The AV cushion will be affected.
Okay, where is the AV cushion? Okay, that's fine. It's called endocardial cushion defect. Nowadays we don't call anymore endocardial cushion defect. That's an old name for it. So basically there is a problem in the ventricular septum, atrial septum, and atrioventricular valves. In other words, it's a mitral valve and tricuspid valve. So the problem of these four things together, it's called AVSD. It is not synonymous with ASD and BSD. It's an association. There is a problem with the atrioventricular valve. We don't call mitral and tricuspid in case of AVSD. AVSD, you call it as left AV valve and right AV valve. For the, it's not because it's not a single, it's a single valve. It's not two valves. So AVSD will have a single valve with a 5 leaflets, and this is called AVSD. And what is PAPVC? PAPVC is partial anomalous pulmonary venous connection. That means instead of 4 pulmonary veins entering into the left atrium, sometimes only 2 will enter into the left atrium, 2 will go to the right atrium. And then you got a PDA. PDA is right between your pulmonary artery and aorta, and AP window. AP window is aortopulmonary window. There is a gap between the pulmonary artery and aorta. So these are the conditions with the acyanotic and acyanotic obstructive lesions. So basically, wherever there is a valve, there is a narrowing, it's called an obstructive lesion. There are so many obstructions, but common things you have to remember: aortic stenosis, pulmonic stenosis, and the coarctation of the aorta. This comes acyanotic. Cyanotic with a reduced pulmonary blood flow, cyanotic with increased pulmonary blood flow. The reason why you should understand, if you have a cyanosis, then the second question you should ask, you may be able to do a chest x-ray and find out how this is a pulmonary plethora or pulmonary oligemia. So the important thing will have, it's a mixing problem with the increased pulmonary blood flow. Reduced pulmonary blood flow is a problem with the pulmonary valve. There is a pulmonary stenosis in case of tetralogy of Fallot. In case of, there may be a pulmonary atresia. That means no forward flow across the pulmonary valve. So if there is no valve, across the valve there is no blood flow, it's called a reduced pulmonary blood flow that causes cyanosis, that you see in the x-ray as a pulmonary oligemia. This has a completely different management comparing to the increased pulmonary blood flow. In the case of, so you, for the remembering the cyanotic congenital heart disease, you have to remember the important 5 T's. First T is tetralogy of Fallot, second T is a tricuspid atresia, third T is a TAPVC, fourth T is a TGA. TGA is basically transverse great vessel. Basically, instead of pulmonary artery arising from right ventricle, it will arise from left ventricle, and aorta will arise from the right ventricle. And truncus arteriosus. Truncus arteriosus, simply instead of having 2 outlets, there is only 1 outlet. So there is no pulmonary artery, no aorta. The single outlet will come. That's a truncus arteriosus. These are the 5 T's you have to remember. Other things I just mentioned: single ventricle with a TS, single ventricle with a no TS. That means what? So you got instead of having 2 ventricles, you will have a one ventricle, either right or left. Morphology will have. So it's very easy to remember. Cyanotic heart diseases: 1, 2, 3, 4, 5 T's, and the 6th one is a single ventricle with the TS, without the TS. With the PS, it comes under the reduced pulmonary blood flow. Obviously, as its name suggests, there is a pulmonary stenosis, there will be a reduced pulmonary blood flow. And the last one, but it's very important, is called pulmonary hypertension. This pulmonary hypertension, in other words, there is a name called Eisenmenger syndrome that will be with the congenital heart disease related. Even sometimes without congenital heart disease, they will get a pulmonary hypertension. So pulmonary hypertension is the complication which we don't want to see. Whoever is attending this session, if don't miss any congenital heart diseases that will go to pulmonary hypertension, then you can't treat the child. And even if you treat, it's very costly, and the morbidity is very high, mortality is very high. So end of this session, if you are able to identify the congenital heart diseases, and if you able to appropriately refer to the appropriate persons right time to prevent pulmonary hypertension. As long as you prevent this pulmonary hypertension, this complication, that's more than enough. That's your practically, it's very important. You're going to be a doctor very soon. In 18 months time, you're going to practice on your own, but never ever miss the pulmonary hypertension. So never ever, whoever you see the patients, whoever you come across, you never make them to become a pulmonary hypertension. Okay, so we are talking about so many things about so many congenital heart diseases. Why should I should know all these things? I am going to practice as a general practitioner. I am going to see an adults and I am going to see children. I am going to see a maternal medicine. So many things. How can I remember all these things? So you don't really remember anything. You just remember only three things. One is cyanosis. Cyanosis, you really don't need too much to pick up cyanosis if you have a pulse oximeter. During this corona time, now everybody is aware of this pulse oximeter. So it's very easy to give the pulse oximeter to your staff nurse or whoever is helping you, ask them to do. All the children, whoever attending your clinic to get the saturation checked. If you're able to check the saturation, you can pick up 30% of congenital heart disease, even they to come and see. Even before they come and see, you can pick up. Other thing, shock. The children sometimes present with the shock. This will usually will happen in the newborn age group. So neonatal age group, sometimes they will present with a shock. So the shock will present if there is an obstruction to the blood flow. If there is an obstruction at the level of vital area, or if there is an obstruction at the aortic level, they may present with a shock. Or if there is an obstruction in the pulmonary level, wherever there is no blood flow flowing through the valves, they will present with a shock. So obviously, you know how to treat the shock. You may have so many sessions. You have to deal with your ABC, the airway, breathing, and circulation. So the same thing you have to apply here. Then in that case, if you suspect there is a congenital heart disease, then you get the echocardiogram, and you can pick up things and you can do. And you are facing in a neonate, you are seeing in a newborn unit, and you seeing some child with a shock. What do you do? One of you can answer. What do you do if you see a child with a shock in a newborn ward? You are posted in a newborn ward. In a few months' time, you're going to be house surgeon, and you see a child with a shock. What do you do? One, two, three. Three things.
Maintain airway,
Correct. Airway. Number two, breathing.
IV fluids.
Circulation. Yes. ABC. Yes. That's very important for all children with a shock, not with a congenital heart disease alone. Yes. You tube the child, and you maintaining the breathing, and you gave some fluid. Very good. You treated the shock. So what cardiac medication you may consider to give children with a shock in a newborn period? Maybe I can tell a 10 days old baby. Okay, so basically there may be a duct dependent lesions. What is duct dependent lesions? There may be a PDA which helps the circulation between your systemic and pulmonary. The duct may close at the age of 10 days or sometimes in a week time. Then the child will go for a shock. So you have to open up the duct for with the prostaglandin. So you have to use the prostaglandin to use the shock. It's children who presented to you with a shock, you treat with the ABC, and if you think so, that maybe the prostaglandin is one medicine you have to think. Other differential diagnosis, if you see a 10-day-old child with a shock, is there may be an inborn errors of metabolism, or there may be a problem with the, so sometimes they may be associated with the respiratory problems and cardiac problems, inborn errors of metabolism, and sepsis. So the moral of the story, you are in there in the newborn ward and you see a baby, and the baby presented with a shock. You secure the airway and you breathe. You make sure the baby is breathing with the airway support with the ventilator, and you give the IV fluids, and you don't get any help from the cardiologist in the during your time. Then you can safely can start prostaglandin if it is available. Then that may open up the duct and child may improve. Number one. Number two, so you can't suspect all the children with a shock as a congenital heart disease. Other thing you have to rule out, you have to give an antibiotics. You may think there may be a septic shock, give you an antibiotic. Number three, you suspect there may be inborn errors of metabolism. You do a arterial blood gas. There you can assess whether there is an acidosis or alkalosis, whether it's lactic or whatever. So the simple stories shock children. If you see in your newborn unit, you get these three things done. ABC, and then just remember prostaglandin, and remember antibiotics, and just do rule out any inborn errors of metabolism. Antibiotics, if you covered, sepsis will be covered, and prostin, if there is a heart problem, it will open up the duct and child will improve. And the third thing, inborn errors, it's difficult challenge for even if you diagnose also. So you are preventing two things. Antibiotics is available and prostaglandin is available, you can use it. And third spectrum of clinical presentation is your acute congestive heart failure. Acute congestive heart failure, it won't present in a single day. It takes a few days to develop. So obviously, how do you pick up congestive heart failure in a baby if you see in your clinic? So what are the two things or three things you see in a child with a congestive heart failure? One of you?
Edema.
Edema will be how you see as a clinically. You see the baby is having puffiness around the eyelids and the pedal edema.
Puffiness of face.
Okay.
Resacral edema.
Yeah. Okay. Basically, it's a new small babies. It's very challenging to do. You see the tachypnea and you see the poor weight gain. These are the two signs for the heart failure in the babies. So again, it's not you. You have to just to lift the top and you have to see the subcostal recessions. If you see somebody with the subcostal recessions and you see the child is not gaining weight by the growth chart. So again, the growth chart your staff nurse can help you to get. So you get the saturation and you see the weight gain is poor and you lift the shirt and see there may be a respiratory distress. And if there is a cough and cold, you can think about probably respiratory cause. And there is no cough and cold, you have to suspect cardiac disease. So cardiac failure to pick up for the clinician is simply getting the poor weight and getting there may be a problem with the breathing. So it's a end of the day, it's very easy to pick up these three things. So you just get the saturation, you get the growth chart, and you lift to the top and see if there's any problem with the breathing. And the shock one, the commonest cause for the shock in the 10 days old baby is coarctation of the aorta that can be picked up by seeing the pulse of the femorals. So we got so many conditions, but you narrow down into a simple algorithm of getting the weight gain and getting the saturation and respiratory rate and femoral pulse. So it's very easy to pick up. How do you evaluate? I already mentioned to you failure to thrive, feeding difficulty, dyspnea on exertion, effort intolerance, frequent chest infection. These are the important terms you have to use in your exam. When you are presenting a long case, you have to use these words. When you are writing the exam theory question, you have to write this one. You can write for everything this one, like vomiting and nausea for the pharmacology drugs. You can write these things for any pediatric cardiac problem except cyanotic heart diseases. For the cyanotic heart diseases, you can say failure to thrive. There is a problem with the cyanosis and cyanotic spell. So it's very easy. Writing for the cyanotic heart diseases, a few things, and acyanotic heart diseases, things. Physical examination. Again, as I mentioned earlier, saturation, weight, and you have to get two things. You have to feel. You have to feel with your hand palm to get the is it hyperdynamic precordium or you got a systolic murmur. As I mentioned earlier, the systolic murmurs above the nipple line you best heard, you think one. Either it's an ejection systolic murmur. You can't call above nipple line pansystolic murmur, never. Never ever get pansystolic murmur above the nipple line because you don't have any shunts across that area. You got only the valve. Aortic valve, pulmonary valve, you get only ejection systolic murmur. Shunts, VSD, you will get the pansystolic murmur. Anything above nipple line, best heard is ejection systolic murmur. The diagnosis is ASD, pulmonary stenosis. Maybe if it is a murmur which is continuous is PDA. Anything below nipple line, congenital heart disease, only one diagnosis, that's called VSD. So it's easy to pick up. Physical examination. Investigation we already discussed. How do you manage? The managing congenital heart disease is not very difficult. So again, it's very easy to manage the congenital heart diseases. Either if the child is very well and you heard only murmur, then you can say like no medication and follow. You can ask them if the child is gaining well, saturations are normal, no breathing difficulty, you can ask for an elective echocardiogram by cardiologist. It's very easy. Again, if already we discussed medication for shock, prostaglandin, heart failure, and cyanotic spell. I'm going to discuss in my next few slides how do you treat heart failure and cyanotic spell. I will tell you there. We already discussed about shock and prostate. The surgery. Whenever they say surgery, there is a complete repair. In case of VSD, you can completely repair. But in case of single ventricle, you can't do complete repair. It's called palliative stage repair. You got a single ventricle. How do you manage a single ventricle? What is the role of two ventricles? One of you quickly you can tell. I think time is going up. So what is the role of two ventricles in normal heart? Okay, one supports the pulmonary circulation, other one supports the systemic circulation. If we got one ventricle, we will go for systemic circulation support. Then how do you get pulmonary circulation support? Simply you get your SVC and IVC directly to pulmonary artery. It's called Fontan surgery. It's a palliative surgery. You got one ventricle, you have to support the two circulations. You just ignore the right side circulation. Instead of IVC, SVC goes to the right atrium, that directly goes to the pulmonary artery. Thereby, you just to bypass the right side of the circulation. So it's called palliative surgery. PA band. What is PA band? If there is an increased pulmonary blood flow across the pulmonary artery, then it's called. Then there is an increased blood flow, then it will go to pulmonary hypertension later on. You want to restrict that one, you will put the PA band. You just like you put the 3 knots across the pulmonary artery, then you restrict the blood flow. Once a child grown to a certain weight, you will go for a complete repair. And BT shunt, you are all aware of BT shunt. If there is not much pulmonary blood flow going through the pulmonary valve, if it is a small baby, if you can't go for a complete repair, then you go for a BT shunt. You just connect the systemic circulation to the pulmonary shunt. And transplant, it's not a good option. So if you say managing congenital disease, these are the things you should remember. No medication, surgery, 1, 2, 3, 4. So VSD, I think you can see very clearly where exactly the VSD point is here, right ventricle, left ventricle across the VSD. And what's the percentage of congenital disease with the VSD? 25%, and 90% located in the membranous and 10% in the muscular. So this question they were asking types of VSD. You can say membranous and muscular, and these children will be symptomatic at the 2 months of age. They will develop CCF. So this is a mechanism. I think for the time we don't have much time. Maybe we can have one more session about if people are interested. But you get CCF at the 2 months of age, and they have treatment chest infection, dyspnea on exertion. And the types of VSDs they mentioned earlier, I think this question they may ask in exam already. I think they asked once. It's you have to just below your pulmonary artery, it's called subpulmonary, and below your aorta, it's called subaortic, and near the tricuspid valve, it's called membranous. And if you have a problem in the muscle, it's called muscular. And so you remember these 4 types: subpulmonary, subaortic, so muscular, and perimembranous. So that you can see in the below picture. So clinically, what you do, you have to differentiate pulmonary hypertension. This is what I was telling you. Don't ever miss pulmonary hypertension. So children will usually present with you with the respiratory distress, means they are not having pulmonary hypertension. So the natural history, children will be normal. The VSD will develop in 2 months of age. Then they will develop respiratory distress. After some time, it will become normal. So you should be either the VSD closed or they develop pulmonary hypertension. We don't want to miss that window period. So somebody presented to you with a respiratory distress, and after some time the symptoms improve. 2 choices: one, the whole closed, VSD normal, or other one, they become pulmonary hypertension. So don't ever allow to go to pulmonary hypertension at that point. So you have to catch before they becoming pulmonary hypertension. So these are the things you will get in the pulmonary hypertension symptom. So small VSDs are asymptomatic, spontaneous closure usually by 3 years. Moderate and large, you have to be careful. How do you pick up moderate and large? So the murmur you get is pansystolic murmur, and the large VSDs, you get a flow murmur. If you get any, the question they may ask you. So when do you worry if you have a murmur? Transystolic murmur, safe. If you have an additional MDM, mid diastolic murmur, then that may be a complication and the child is having a large VSD. If you leave them, they will become pulmonary hypertension. So complications of VSD. So they develop pulmonary stenosis and they develop pulmonary hypertension and they develop the aortic regurgitation and they're prone for infective endocarditis. I think these complications we can explain in nicer way, but I think for your exam level, you just remember these complications. People have a doubt, we can discuss again. Treatment, you control the CCF, treat the chest infection, treatment of anemia and infective endocarditis. Surgical closure, infants with a failure, you close, large shunts, you close. Subpulmonic VSD, even if it is small, still you have to close it. The reason is they develop aortic regurgitation. So surgery is not indicated, small VSD and pulmonary hypertension. If somebody develops pulmonary hypertension, you are not supposed to treat. If you close the child VSD with a pulmonary hypertension, they will die at some point. So it's better to leave them, they will live longer. So children with a VSD and pulmonary hypertension live longer, better if you leave them alone rather than treating. If you treat them, they will die early. So other methods of treating catheter closure, you just remember muscular VSDs can be closed by catheter, the angiogram. So the PDA, so you can see where is the PDA, it's there, and this is the pulmonary artery and this is aorta. You common in preterms, and if you get the term baby, you get a left to right shunt, it's an acyanotic heart disease, you get a continuous murmur. The management, newborn, you can use some medications, ibuprofen, indomethacin, and you can close this by angio using the coils or device closure. And small babies will have a ductal ligation. If somebody is on ventilator and if it's not coming out of the PDS, the baby is not coming out of the ventilator and the child got a PDA, even we can ligate the duct by surgically, even if there are 800 grams, 900 grams, still you can treat it. So no weight limits for the treating the PDA. 700, 800 grams also you can treat by giving the ductal ligation. And child is slightly bigger, 7 kgs, 8 kgs, you can do easily using the angiogram, either coil or device closure. Tetralogy is a very important one, important topic. So tetralogy has a components of 4: pulmonary artery stenosis, right ventricular hypertrophy, overriding of the aorta, and large ventricular septal defect. You just remember the tetralogy 4. And pentalogy is you will have associated ASD. So pentalogy of Fallot is associated with the ASD. So most common congenital cyanotic heart diseases and symptoms is cyanosis, we discussed, and the questions they commonly they will ask you if they don't develop congestive cardiac failure because there is no blood flow across the pulmonary blood flow. So no blood flow to the pulmonary circulation, then they don't develop congestive cardiac failure. But if they develop congestive cardiac failure, that means they have an associated problem. You just remind yourself anemia, infective endocarditis, hypertension, RV dysfunction, and there may be regurgitation. So you have to be able to say these 3-4 things if they ask you in an exam. If they have a long case, or even in case of your theory, they may ask you this question: if they develop CCF, what that causes? And signs, as you already know, clubbing, cyanosis, ESM. If you see a clubbing child in your final year exam and if they say it's a cardiac case, you have to think about it's a tetralogy, that's the commonest thing. And other thing is the pulmonary hypertension. Usually they don't keep pulmonary hypertension in exam. So you have to diagnose it as tetralogy of Fallot, confirm that with the cyanosis, and you hear a ejection systolic murmur. So there is a murmur. What is the VSD murmur you will get in tetralogy of Fallot? One of you quickly, what murmur you get across the VSD? One of you? No? I can see 2 names here. I can ask one of you. Jayashri? Jayashri? Okay, that's fine. So, no murmur across the VSD. The murmur, why you get the murmur? Normally, there is a pressure difference between ventricles. But in case of tetralogy of Fallot, the right ventricular pressure is equal to the left ventricle, so you don't get the murmur. So, murmur, whatever you are hearing in tetralogy of Fallot, it's coming from the right ventricular outflow obstruction, that's the pulmonary stenosis murmur. Pulmonary stenosis, you get murmur is the ejection systolic murmur. So tetralogy of Fallot, across the VST, no murmur, only you see the murmur across the pulmonary valve. Cyanosis in TOF is squatting cyanotic spell. This is very important thing you should remember. So squatting, children, the patient assumes a sitting posture as soon as they get dyspnea. This is in the children. What will happen to the smaller babies? They will develop a spell. What is spell? The child starts crying. You're able to describe. I think these points, everything in your OP guide, but you're able to say exactly the words. If somebody asks you to describe the spell, and if you have a chance to see one, you will never forget. But if you are unable to see, but still you can remember this. Child cries, incessant cry, irritable, inconsolable, tachypnea without subcostal recession, bluer than before, gasping respiration, apnea, LOC, loss of consciousness. So this is the order they will get. Cry, incessant cry, inconsolable, tachypnea, bluer than before, they will become more blue and they will lose the consciousness. You are able to describe this exactly the same words. How do you treat? Again, the treatment is ABC. Anything emergency in pediatrics or adults in medicine, surgery, it's ABC. Next, you have to, child is very irritable, you have to sedate with a morphine too, just to make the child sedate, thereby child will become quiet. So morphine is very important. Then you treat sodium bicarbonate for acidosis and correct hypovolemia if there is anything. If there is anemia, you transfuse and you give beta blocker to reduce the heart rate. And still you have the desaturation continues, you have to go for ventilation. So you paralysis. So you have to ventilate and you have to give paralytic agent, thereby child will have in quiet and usually this spell will settle. So you have to give one medicine called phenylephrine. Phenylephrine is, I think you read about it, it reduces the, it increases the SVR. So what is the reason for cyanotic spell? The cyanotic spell is because of there is a discrepancy between your systemic vascular resistance and pulmonary vascular resistance. I think the textbook they given something like infundibular stenosis spasm. So there is muscle will never go spasm. Cardiac muscle will never go spasm. I think it's a misnomer, but I think Guy says you just follow it. But infundibular spasm is not the reason for cyanotic spell. Cyanotic spell will due to difference between your pulmonary vascular resistance and systemic vascular resistance. So you have to reduce the pulmonary vascular resistance. You have to increase the systemic vascular resistance. That's the reason why you keep the knee chest position. If you keep the knee chest position, there will be increased systemic vascular resistance. So you are just compressing your great blood vessels. So the femorals will compress and blood won't go to the body. It will stay into the pulmonary circulation. So you remember that. Following spell, you give the treatment beta blocker and early surgery. I think this question they are asking in your theory question, even they may ask you in your clinicals. TOF treatment, I think you prevent complications. You have to surgery, you can do surgery safely by even 7-8 kgs you can do. If not suitable, go for a BT shunt. Treatment is, I think we just very quickly, we'll go for a few radiographs. I think 5 more minutes are there. So you can stop me anytime if it is 6 o'clock, or if you want to continue, you can continue extra few minutes. Just differentiate between these two radiographs. One is pulmonary oligemia, and this one is a pulmonary plethora. It's very obvious. It's you can say it's increased pulmonary vasculature here, and here there is an oligemia. There is not much. So this is to differentiate if you have a cyanotic kit and increased pulmonary blood flow is this, and this is going for a reduced blood flow. TGA, you get an egg-on appearance. Can you see that X-ray where it looks like egg? And you don't really need an X-ray to diagnose TGA. You can easily pick up with your saturation and child, low saturation. You see them, consider TGA, and you can confirm within few minutes using the echocardiogram. TAPVC is a pulmonary veins. Instead of going to the left atrium, it goes to the right atrium, and it causes the through the AST the blood will move. So it's a TAPVC. You can see this snowman appearance. That's what the X-ray shows. Boot shaped. TOF is very common. I think this you should know. They may ask you in exam and they may ask you even in your orals. The boot shape is a tetralogy of Fallot. ECG, you should remember two things. One is a left ventricular hypertrophy, right ventricular hypertrophy. So then you should know causes of left ventricular hypertrophy and right ventricular hypertrophy. Then whenever they ask you that condition, you can just say in your ECG this finding. So I already mentioned to you, key to pick up congenital heart disease are weight, saturation, femoral pulse, respiratory rate. You remember this slide for your practical thing. And if you remember all this 1 hour, if you forget everything, but you remember these 4 things, and you can pick up all the congenital heart disease. I can guarantee you never miss if you follow this algorithm. Weight, saturation, femoral pulse, respiratory rate, you pick up all the diseases. So murmurs, so we can briefly mention whenever you describe the murmur, you have to say, is this a lesion murmur or is a flow murmur? In VSD, you get ansystolic murmur and the sound is like a burr, B-U-R-R. If you say faster, that's what you will hear the sound in VSD. The flow murmur is MDM, you hear like lubbed up, duh. And POF, you hear VSD, no murmur, as I mentioned. You get a PS murmur, it's called ESM, and it's a burr and dub. So it's similar to PSM, but you get a dub. You can hear. Lub is the first sound, dub is your second sound. And if you hear this burr alone with no lub and dub, it's a PSM. And if you hear the lub and dub and you heard duh, it's a MDM. And we hear the no murmur and only hear the burr and dub with the cyanosis, it's a tetralogy of Fallot, and you hear the continuous murmur in the PDA. So these are the murmurs you should know for your level for congenital heart disease. VSD murmurs 2, tetralogy murmur 1, PDA murmur 1. So I will try to play these murmurs if possible, then you can hear that one. So quickly about the Eisenmenger syndrome. What is Eisenmenger syndrome? It's a severe PHT resulting in right to left shunt at the atrial level, ventricular level, and pulmonary arterial level. What it means? ASD, VSD, PDA. So these are the things. If you leave them for a longer time, they will develop the right to left shunt, pulmonary hypertension. That's called Eisenmenger syndrome. So this you don't want to allow any of the child under your care to become severe PHD. It's very important. So next one, so Eisenmenger complex, usually they will call VSD and PHD. And clinically you see cyanosis and clubbing. The management ideally should be prevented, but if somebody miss that you can't really help, that you have to go for a management. How do you manage? You manage with the, so the definition is that if you have a mean pulmonary arterial pressure is 25 mmHg and the etiology is congenital heart disease, respiratory distress, upper airway obstruction, connective tissue diseases, even in the liver diseases you will get, and PPHN. What is PPHN? So the PPHN is the pulmonary vascular resistance elevated after birth. Pulmonary vascular resistance usually should drop after birth, but if it persists, it's called PPHN. It's a persistent pulmonary hypertension in the newborn. And the common causes meconium aspiration syndrome, perinatal asphyxia, and congenital diaphragmatic hernia. So what you do, you do ventilation and you high frequency oscillative ventilation and nitric oxide, even you may need an ECMO, extracorporeal membrane oxygenation. So symptoms of pulmonary hypertension, you get dyspnea, hemoptysis, chest pain, cyanosis, syncope, arrhythmias. Treatment, diuretics and vasodilators. You just remember these two, sildenafil, tadalafil, and endothelin receptor antagonist, bosentan and ambrisentan. And surgery is a treatment of choice in case it all fails. It's heart and lung transplant. The problem not only with the heart, there is a problem with the lung because all blood vessels become arterialized, then you have to treat. So transplant is the treatment for pulmonary hypertension. If medication fails, again the issues with the transplant is immunosuppression and they are prone for infections. It's not that easy to go for it. So I'm just going to play some the murmurs. If you are able to hear, you can hear. But if you have any difficulty to hear, probably we will complete the class here. Can you hear?
No, sir. Yes, sir. Yes, sir.
Okay.
Sounds a bit like bird. See if you can.
No, sir. We can't hear.
Can you hear?
No, sir.
I think. Can you hear, ma?
No, sir.
Okay, that's fine. I think it's not coming.
Okay, sir.
Okay, so Suresh? Okay,
Okay, sir.
yeah,
Thank you,
probably
sir.
I think I will try to send this. If we can hear that murmurs. I think you should know these three murmurs that's enough.
Yeah,
Ancestolic murmur,
sure,
ethnic
sir.
murmur,
Thank
and
you.
systolic murmur. Yeah. So, any questions? You got any other class now?
No, sir. We don't have any class, sir.
Okay. So, any questions for any? Any questions? So I think I'm a bit rushed some of the topics. So because of the 1 hour, I think it's covering the whole content knowledge is a bit challenging. But you guys have any doubts? You can contact, you can send a message.
Okay, sir.
So I think Salo,
Thank you, sir.
yeah,
Thank you, sir.
the squatting
Thank you,
increases venous.
sir.
There's a one question that squatting increases the venous return. So what will happen to the squatting? So the mechanism of squatting is a protective mechanism. The child tries to, basically it's like a cyanotic spell. Child feels cyanotic spell. The babies can't tell. That's why the babies will cry. But children with this squatting, what they are trying to do, they're trying to do the mechanism of try to increase the SVR, try to reduce the pulmonary vascular resistance. I think if you take rest, your pulmonary vascular resistance will come down. And but if you just do squatting, you're going to sit and you're going to pull your blood, more blood into the lungs rather than the systemic. So systemic circulation, so systemic, so if the pulmonary and systemic will have an equal balance ratio. It's called QP/QS ratio. The QP is the how much blood in the pulmonary circulation. QS is how much blood in the systemic circulation. It should be always 1:1. So what happens during the cyanotic spell? The more blood will go to the systemic side. So you try to reduce this blood going to the systemic circulation. You do the squat. Okay? Yeah, that's fine. Thank you guys. I will
Thank
leave.
you, sir.